Copyright Stanford University, all rights reserved.
So we're going to get started. We just have Mark. Okay. Thank you very much. It is a real privilege to welcome one of the leading scientists and clinicians in pulmonary vascular disease in the world today, Dr. Norbert Völkel, who has had an illustrious career and led to a lot of his work has led to a lot of pivotal discoveries in our understanding of hypertension. And if Norbert remains true to his style, I think you'll find he is very artistic and integrative, and he actually is an artist with 2 galleries in Taos, New Mexico, which is a testament to his multifaceted talents. I did want to say that Norbert is an example of how cream rises to the top. He was born in Bayreuth, which is the home of Wagner in post-World War II Germany, and grew up playing on the slag heaps of that time. I guess it was Hitler loved Wagnerian operas, so it was a major target for the Allied bombers, and that probably had some influence on his artistic sensibilities and intellectual development over time. He moved to Upper Franconia in the shadow of the Iron Curtain, where he was raised, and he developed an interest in psychiatry at an early age, and did his doctoral thesis in the division of psychosomatic medicine before getting tired of not having adequate therapies for the diseases that he was seeing, and he became attracted with good mentorship to lung disease. He met his soon-to-be wife, an American surgeon in Germany, and was convinced to do lung research in the United States, and made a great decision by moving to the CVP lab in Denver, which, as many of you know, was the birthplace of a lot of pivotal science. When Norbert started doing his research, all that was known in the 1970s about pulmonary hypertension was really about hypoxic effects on the pulmonary vasculature. And when he joined the CVP lab in the 1970s, he really helped bring the field forward. He's the author of more than 300 publications, including multiple senior author publications in Science, New England Journal of Medicine, JCI, Circulation, etc. He's a member of the ASCI, and he has influenced the field in numerous ways, most recently and maybe importantly in developing the animal model that's currently the most used animal model in pulmonary hypertension research. In Colorado, he led the pulmonary hypertension program there. This is the largest pulmonary division in the world with over 100 faculty members. He was actually recruited away. The same time I came to Stanford, he went to VCU, where he was directing the Brooks Mirren Center for Translational Research, as well as the Victoria Johnson Center for Emphysema Research. And this morning, he's going to give us a talk on an area that he's eminently qualified to talk about, which is right ventricular failure. The NIH actually called on Norbert, as someone who had been interested in this area for a long time, to actually develop the RFA that I think a lot of you in the room may have participated in. Norbert helped to design and actually lead the team. I consider Norbert largely responsible for the field moving from being exclusively focused on the disease in the pulmonary arterioles now to share some justified attention in the right ventricle. So without further ado, I'll welcome Norbert.
Good afternoon. Thank you very much for inviting me, and Mark, you for your kind introduction, which was not entirely deserved. I'm very happy to be here and have you as a captive audience for the next 35 or so minutes. And don't expect any transgenic mice experiments in my talk. What I'm trying to do is to give you a little bit of a big picture hypothesis generating talk. I have to admit right off the bat that many of the things that I will talk about and tell you have huge gaping holes in there, and so this is not because of a lack of rigor or stringency on my part, but because of the amount of work that still has to be done. So I want to make a case for microvascular pathology in chronic right heart failure. That's the example that I'm choosing, and I'll leave it to you in the audience to figure out for yourself whether that also applies to the left ventricle. 1995, people still felt compelled to write a paper with the title "The Forgotten Chamber: The Importance of the Right Ventricle." And the authors from Duke used this mechanism of educating people and stating that the right ventricle has a smaller mass than the left ventricle, smaller diastolic pressure, receives blood flow in both systole and diastole, lower O2 requirement, RV is more compliant than the LV, and accommodates increments in volume better than the LV. And then later on, Dr. Quaife in Colorado did studies on hypertrophy and stated that RV hypertrophy counterbalances wall stress, enhances ejection performance, and we at this time started to think about the importance of RV function in the setting of pulmonary hypertension. So at this moment in time, the RV is no longer forgotten, but still needs a lot of work. Put this in perspective, as Mark introduced me, I grew up in the physiology laboratory, the CVP lab in Colorado, and had the opportunity with my mentor at this time to review what was known at the time about primary pulmonary hypertension, now bashfully called idiopathic pulmonary hypertension. And I quote this because to some degree this may be still state of the art, and this is 1979. And it says few data dealing with the measurement of right ventricular contractility in primary pulmonary hypertension patients are available. And then we reference a study from Germany, the study of Degenring, which demonstrated that the maximal rate of right ventricular pressure rise was 5 to 10 times the normal value in pulmonary hypertension. With exercise, the right ventricular oxygen consumption was 5 times the normal value and did not fall promptly when exercise stopped. Increased myocardial norepinephrine probably contributed to the augmentation of the RV contraction and to the uneconomical increase of the myocontractility and oxygen consumption. So at that moment, there was this idea that the pressure overloaded right ventricle was working in an uneconomical fashion, and that's probably still true. Fast forward in 1997, I was called upon to run the Aspen Lung Conference on pulmonary vasculature and pulmonary hypertension, and I had the good fortune to invite Michael Bristow, then the chief of cardiology in Colorado, to give a state-of-the-art talk. And this is important. So he started out, there are excellent data implicating RV function as an important determinant of the natural history of pulmonary hypertension. However, in this disorder, RV dysfunction has not received the kind of investigative scrutiny that pulmonary vascular mechanisms have enjoyed. This is partly because subjects with PPH are cared for by pulmonologists, whose investigative interests are focused on the lung rather than the heart. So here you have it, this is 97. One of the fundamentally important questions surrounding PPH is that subjects differ substantially in their tendency to develop RVF. That is still true, and we don't understand why. This leads to a variable natural history, therefore mechanistic hypothesis for the development of RVF need to accommodate this biological variability. Well, here you have it. This is the way the pulmonologist looks at pulmonary hypertension. It's all lung circulation. And this is how many cardiologists, none in the audience of course, deal with pulmonary hypertension. There is no lung. That's the problem. And we have to somehow bring these two organs into a dialogue. As Mark mentioned, 2005, the person in charge of pulmonary hypertension, Dorothy Gale, called me up and said, we have $10,000 left in the kitty, just enough to do a workshop. If you had the choice, what would you think the workshop should be about? And I didn't hesitate and said, it must be the right ventricle. This resulted in this paper. And now, more recently, at the WHO meeting that Francois Haddad in the audience attended and co-authored, came out with a position paper, state-of-the-art, the right heart adaptation to pulmonary arterial hypertension, physiology and pathobiology. It's a very promising title, but when you read the paper, and Francois will admit, there are still lots of white spots on the landscape and many holes that we have to work on. Well, it starts with the fact that the RV is difficult to see and to visualize, and it's also very different. You find this heart is one of the art pieces of Jeff Koons, and he's selling these hearts for lots of dollars. So an important pulmonary arterial hypertension therapy goal, in my mind, is to maintain RV function in the setting of chronic afterload and RV stress. So in principle, when we say that, we are not negating strategies that attack the transformed lung circulation. Well, what we are saying is that in case we are not successful in changing the remodeling, changing the appearance and the dysfunction of the lung circulation, we might as well take a look at the RV. So I want to go through in the next 25 minutes 3 hypotheses with you. One is the postulate that activation of the neuroendocrine axis and of inflammatory pathways drive the RV being compensated into frank failure. And that failure is actually characterized on a tissue level by apoptosis, impaired autophagic flux, capillary loss, and fibrosis. So there is an attempt here to identify the failure by morphology and by impaired cell function. Underlying these alterations may be a mitochondriopathy and metabolic remodeling. And at this moment, if you ask me, is it really the root cause? I would say I don't know. I would much rather think it is coming with the territory of failure. It's there, but it may not be, at this moment in time, a treatment target. Second hypothesis is one that I think could be a lot of fun for a lot of cardiologists to work with, which is that the sick lung circulation reprograms the microcirculation of the heart, which is impaired in right ventricular failure. So I say this again because it's kind of important as a concept. The sick lung circulation reprograms microcirculation of the heart. What it means is that the sick lung circulation sends out information that is misleading and has an effect on the next capillary bed, which happens to be coronary circulation. And it would follow that this kind of concept would explain also left ventricular problem, not just right ventricle. And so then the even more provocative statement, I think, the health of the lung endothelium determines the health of the heart. We start with putting the elements of failure together. We can think about the neurohormones. A bit is known about that. We have to talk about hypertrophy as important on the right ventricle, apoptosis as a cellular failure and demise signal, that both hypertrophy at some point in time and dilatation will cause ischemia. I think ischemia also because of a problem with the microcirculation. And ischemia, most people would accept by itself, will lead to inflammation and to changes of the extracellular matrix. In that package is a reactive oxygen species and reactive nitrogen species disequilibrium. So, hypothesis for right ventricular failure then and repair on the level of microvessels are going to one particular protein, vascular endothelial growth factor, isoform B, and I will give you two examples that we have experimentally that would begin to approach the question, well, so if the microcirculation is sick, what are you going to do about it? Can that be approached? Can there be an effect that would improve the function of the microcirculation? I had, in my work in the last decade, first to overcome a dogma which was very much established in mainstream cardiology, which is any cardiac hypertrophy is bad. We didn't believe that. In chronic pulmonary hypertension, the RV can adapt and sustain function not only in spite of the 4- to 5-fold increased afterload, but because of hypertrophy. I would stick my head out and say, unless there is hypertrophy, there is not going to be an adaptation to the afterload and the patient dies. So that's where it's a bit different on the right side. And to illustrate that, this is a case that is now sort of famous in the pulmonary hypertension literature, published by Stuart Rich and Stephen Archer, of a patient being treated for 18 or 19 years. Whoops, I didn't mean that. Not even that. Going the wrong direction. A patient treated with intravenous prostacyclin, and you look at the free wall of the right ventricle, it is really, really robust. So long-term survival together with prostacyclin treatment. Again, when we started treating patients with prostacyclin, the idea was that we were doing vasodilation somewhere. And people did not want to think about an effect of prostacyclin directly on the myocardium. The significance of that case was the patient died from colon cancer, which is interesting itself because of the prostacyclin treatment. I don't have time to get into that. But her lung vessels were absolutely abnormal, and there was no effect on any of the vascular lesions. So we had, for the first time officially, a case, long-term survival, prostacyclin treatment, robust performance of the right ventricle, not a single day of right ventricular failure associated with severe vascular lesions. The second part of that hypertrophy story comes together with when I was a visiting professor in Vermont many years ago, and I finally talked with a pediatric cardiologist. And after listening to me, he said, well, it's not so complicated. All you need to do is to turn the right ventricle of your primary pulmonary hypertension patient into an Eisenmenger ventricle. It's all you have to do. If you can't do that, patients will survive. Well, one of my former associates, Jose Gomez Arroyo, looked at the heart from, as you can see, normals, patients with idiopathic pulmonary hypertension, and patients with Eisenmenger disease, and just look at the wall thickness. And it doesn't matter where you cut at the base, the middle, or the apex, always the Eisenmenger is thicker. And there is also some increase in thickness on the left side, but really not that much. And if you correct these data for the surface area, it also holds. Eisenmenger is always thicker. That's interesting. When we looked at the tissue and took trichrome staining as a marker of fibrosis, we found way less fibrosis in the Eisenmenger. And coming now finally to the microcirculation, which I owe you, an old paper from about 1956 from Cleveland looking at the coronary circulation in Eisenmenger heart, and you can see that there is a much, much greater vascularity there. So it is possible that the Eisenmenger is sustaining the function in the view of the pressure overload and flow overload because of hypertrophy, healthy myocardium, less fibrosis, and more vasculature. So again, to say it for the last time, when the left ventricle is under stress, you have really only a % change in the intracavitary pressure. It's a % change. The pressure, blood pressure goes from 120 to about 200 or so, 60%. Right ventricular systolic pressure goes from 20 to 100. That's fivefold. So what we don't understand is really the cellular and molecular events that account for the transition to maladaptation and this uneconomical performance. We know the RV eventually is uncoupled, is stiff, fibrotic, hibernating. But what is really the first step? So that's the question that at some point in time we need to answer. Let me switch quickly to the question, what determines the pulmonary arterial hypertension treatment success? And is it a decrease in the pulmonary vascular resistance after therapy? And the answer is no, as we know from the study from Amsterdam, where they looked at more than 60 patients with cardiac MRI and found that a decrease in the PVR was not necessarily associated with survival. And this paper is getting a lot of notoriety now, that it was really the treatment effect on the right ventricular ejection fraction. If RVEF and stroke volume increased, the patient had a chance of survival. It was not the pulmonary vascular resistance. And you see that here now in the Kaplan-Meier curve expressed for RVEF of either greater or lower than 35%, and here the association with the change, either increase or decrease in the PVR. Of interest is that when you plot in that study the cardiac output, shown here, delta cardiac output, against the change in the right ventricular ejection fraction, there are enough patients there that have an increment in the RVEF not associated with an increase in cardiac output. I quote this from one of my former collaborators, Ruben Tudor, who very recently, is August of this year, wrote a review paper, and in it he says that this integrated approach is ever more pressing in the right ventricle because our understanding of key structural alterations of the failing RV in pulmonary hypertension is lacking. Well, yes and no. We know actually a little bit at this time, but we need to know more. A recent study from Hopkins group shows that there is a perfusion problem, perfusion reserve problem, and interestingly, both in the right ventricle and in the left ventricle. We are coming around now, the right ventricle friends, the friends of the right ventricle in the setting of pulmonary hypertension, to also ask the question about the left ventricle. What is going in the left heart? It's not normal, for sure. The sick lung circulation heart axis, it goes as follows. The lung as the largest capillary network in the body, and having sick lung vessels that are structurally abnormal, will shed cells, DNA, microRNA encapsulated in microparticles, and a host of mediators that are originating in the lung. How is it possible that all of that stuff that is coming out of the sick lung circulation will not affect the coronary circulation and microcirculation. These are lesions that we are dealing with in the lung circulation. These are so-called plexiform lesions, and they are very complex lesions, but we know that the endothelium in the entire lung is dysfunctional. You can do multiple studies looking at function of enos and other functions. And this is just one example to show you what comes out of the lung, and you have here idiopathic patients and patients associated with connective tissue disease. RA is the radial artery, so that's periphery, and that's the pulmonary artery. And you can see that the level of these proteins is greater in the periphery than coming out of the pulmonary artery. That's true for PDGF, and it's also true for TGF-beta. And that is one of several studies. You find all sorts of other factors, von Willebrand factor, microparticles, etc., coming out of the lung. At this point, I need to pay tribute to a German paper that came from the Max Planck Institute for Cardiology there. And this was a study that I found remarkable because the surgeons at the time of valve replacement took a piece of the myocardium and subjected it to EM investigation and others. And they found capillary rarefaction in the left ventricle. And they found ubiquitin-related autophagic cell death and also apoptosis. So in that setting of left ventricular pressure overload, in the setting of aortic stenosis, there was for the first time an organized, focused attempt to match that with the information that you can get from the tissue with immunohistochemistry and other assessments. So in the heart, the microcirculation is very difficult to study, to look at, to quantify. And this is here from a rat. And if you look at this long enough, you get pretty dizzy because you see that there are anastomoses all over the place, connections right and left. And so how do you quantify the number of these vessels in the different kind of diameters and categories? So admittedly, this is a difficult task. I want to introduce a model that we have used and that taught us a fair amount about the right heart failure, which is the Sugen hypoxia model of severe pulmonary hypertension. Very quickly, I don't want to do much about it because a lot has been published now. It is based on chronic VEGF receptor blockade. It's not spontaneously reversible, and the lung vascular disease is refractory to conventional therapy. The pressures that you get in the right ventricle are, as we see them in patients, up to about 100. Nothing happens to the systemic pressure, and as in patients, we see a significant reduction in the cardiac output. This is early, after about 3 weeks, and this is about 5 weeks. So the heart is definitely involved and is suffering. And this shows you the degree of right ventricular hypertrophy that there is at the time when the right ventricle fails. The lung vascular lesions have resemblance to what you see in patients. They are obliterative and driven to a large extent by proliferation of endothelial cells. And when you look at the myocardium, and this is a in vivo tomato-lectin perfusion, you can clearly see that there is capillary rarefaction, that there is a loss of the microcirculation. You can look at immunohistochemistry markers. In this case, this is aquaporin 1, and you can see here vast areas where there is no staining. Aquaporin 1 is involved in water transport in the capillaries and nutrient transport. And this is a review that you can look at. When we ask the question about endothelial cell function in the remaining residual endothelial cells, capillaries, we chose to look at prostacyclin synthase because that is of interest, as you will hear at the end of my talk. And we were wondering whether the endothelium in the sick right ventricle would express this protein, and in many of these capillaries it does not. So the opportunity to make prostacyclin in that myocardium is not there. And of interest, the prostacyclin receptor expression was also compromised. So both the manufacturing of prostacyclin in situ as well as the target P receptor 3 is not there. And that begs the question, could, if that's the case, prostacyclin treatment affect the myocardium, and how would that happen if the receptors are compromised? When you then take another step and you go to EM and you look at the health of the endothelial cells, you see in many situations that the endothelium is absolutely vastly damaged with bleb formation, and that would be the histological correlate to the functional, meaning that could be the underlying reason why the endothelial cells aren't working, and also have a changed gene expression pattern. You find abnormalities on the level of the mitochondria. They're usually small and bunched up, and you find autophagic events going on in the myocardium, and we don't know, perhaps also in the endothelium. So a working schematic is that we have in the right ventricle under stress, endoplasmic reticulum stress, oxidative stress. We get nuclear and mitochondrial DNA damage. We have unfolded proteins. We have the need for revving up ubiquitination and proteasomal degradation. We have a problem with mitochondrial dysfunction, and we probably also have a problem with defective mitophagy. This shows you some of the mitochondrial genes that are decreased in expression, particularly here TFAM, which is the guardian of the mitochondrial DNA. You have smaller numbers of intact mitochondria in the ventricle, and you have also evidence for mitochondrial dysfunction that seems to be partially reversed when we treat the animals with carvedilol. I'll get to that soon. So a word on autophagy, self-eating. There are probably now several hundred papers on the role of autophagy in the myocardium that is stressed, ischemic, hypertensive, and such. And we thought that we could come up with a hypothesis to say that yes, the initial stimulus is the pressure overload, but then on the cellular level you have the consequences of stress. One factor is ceramide production, accumulation of protein aggregates, and accumulation of damaged organelles. And that you need autophagy to work, to clean up the mess intracellularly, or for short, congestive heart failure on a cellular level is congestion of the cells with waste products that they cannot eliminate. Where the energy problem comes in is that perhaps the energy is not there to get the garbage cans cleaned, get the misfolded proteins out of the cell, because all of the remaining energy in the hibernating right ventricle is being used for contractility, but not for waste managing. So we looked at that in the myocardium, again, control, Sugen hypoxia, and the red stains LC3B2, which is a marker of autophagy. And interestingly, when we treated the animals with established disease for 3 weeks with carvedilol, there were much fewer of these events. So is the failing right ventricle hibernating? If so, how can we characterize hibernation? And that can be done histologically, markers of autophagy, particular proteins like desmoplakin, glycogen deposits, small mitochondria, nuclear envelope crenation. So we know what to look for, and there are molecular patterns that characterize that. This is an example from a explanted human heart from a patient with primary pulmonary hypertension. And I show this to illustrate the lack of caveolin 3 staining in this whole area. So that is known that the hibernating ventricle is spotty, and that there are mosaic patterns of apparently functioning areas with those where the function is not there. And that is an illustration, I think, of this. I need to introduce you to, I think, an important paper from Eli Cashett's laboratory, where he used transgenic mice to targeting the VEGF expression in the myocardium. And by doing that, he consistently introduced hibernation. So VEGF signaling was inhibited, was impaired, and that's all you needed to do selectively in the myocardium to introduce heart failure. When they turned back the VEGF expression, normalized it, it was fully reversible. Which gets me to vascular endothelial growth factor B. There's increasing chatter in the literature regarding this isoform. This comes from the Swedish group. Klaas and Welch is the leader in this group. And this paper established with knockout strategies that the isoform B controls endothelial fatty acid uptake. So it is a controller of microcirculatory endothelial function. If you don't transport the fatty acids, you can't have fatty acid oxidation. So apparently VEGF-B is a strategic position in controlling the health of the endothelial cells. And this is just one figure from their work where they looked at myocardial endothelial cell fatty acid transport, and you can see the difference with anti-VEGF-B antibodies or when inhibiting the signaling with the soluble VEGF receptor. When they overexpressed in the mouse, and this is a very recent paper from Al-Italo's group, they got fantastic capillarization of the mouse heart. So we have data on both sides that point towards this particular isoform B, VEGF-B, as an important player in the maintenance of the health of the heart capillaries. A recent paper of clinical importance perhaps demonstrated that low circulating levels of VEGF-B predict left ventricular remodeling after acute MI. Very interesting, this paper also because of the tie-in between outcome and peripheral signal, a biomarker that is of interest because we know about its function in the nutrient transport across the endothelium. Apologize for this blurry and small picture, but we looked at this particular VEGF protein in animals that were made chronically hypoxic. This is the right ventricle, and you can see how diminished it is in the Sugen hypoxia right ventricle. So we know that there's capillary rarefaction in that model in the RV, and there is a decrease in the expression of this transport facilitator VEGF-B. I want to end with what I promised you before to give you examples, albeit in the animal experiment world, of what we could do to improve the microcirculation in the failing RV. And I first talk about carvedilol. It's a paper published a couple of years ago, which established that in the RV there was a loss of capillary density is decreased, and then when the animals had been treated with carvedilol, there was a return of the number of capillaries towards normal. That's really the only data that I want you to keep in mind from here. The other one is that if we assess apoptosis by tunnel, you see apoptosis in the RV, and that was practically normalized under the influence of carvedilol. We did microarray tissue gene expression studies in the animals with and without carvedilol. You can see here just by the heat plate that there is a difference in the expression pattern. And we noticed that there was a lot going on with ubiquitin pathway gene expression. And when we looked at with a kit that is available, at the relative amount of ubiquitinated proteins, you can see that there is a need for this pathway. We think it's overwhelmed, and we take the return towards normal under the influence of carvedilol as evidence of improvement of the protein, the fate of proteins, misfolded proteins, and a deviation from the path of proteotoxicity. Another marker that is of interest is growth differentiation factor 15. This case, message overexpressed in the failing right ventricle and normalized under the influence of carvedilol. This published fingerprint or expression pattern that distinguishes RV hypertrophy from RV failure. This was a banding model, pulmonary artery banding model, showed that there are differences on the level of several factors, including IGF, VEGF, as I mentioned, and all of these things were practically normalized under the influence of carvedilol. And then we did something very simple. We took a normal rat off the shelf and treated the animal with carvedilol for 3 weeks. Took the heart out and looked at changes in gene expression. What we find is that carvedilol is pro-angiogenic. Just treating the animals with carvedilol increased the expression of HIF-1 alpha, HIF-2 alpha, vascular endothelial growth factor, angiopoietin, apelin, and so forth. So the first information came to us that rarefaction of the capillary microcirculation was reversed, and we think that one possible explanation is that the drug actually is pro-angiogenic. We have so far treated 6 or 7 patients clinically with idiopathic pulmonary hypertension, one with scleroderma, I think, and we found that after 6 months we had improved the right ventricular ejection fraction in really all of these patients. That will be followed up and, of course, needs validation by other research groups. So finally, let me close with an attempt to explain to you how prostacyclin works. I never believed that it worked directly, effectively on the lung circulation. I always thought it works on the heart. Again, this is the image of the patient surviving 18 years on prostacyclin. And what we did together with Actelion, we came up with a protocol where we treated the rats in the Sugen hypoxia model with established right ventricular failure 3 times a day with inhaled iloprost. So you can imagine this was a rather labor-intensive study, 3 times a day through the week and so forth. First thing we found was that we had reversed the fibrosis in the right ventricle. That was associated with a diminished expression of the collagen 1A and collagen 1A3 genes. So we probably have affected collagen synthesis directly with the prostacyclin treatment. As you expected, there was really no effect on the right ventricular systolic pressure when we treated the animals with the iloprost, and we had no influence on the vasculature. The obliteration of the vessel numbers was exactly the same. What happened functionally was that if we put the animals on the treadmill, in other words, we forced them to do a 6-minute walk test, they performed much better. So that was going along with the improvement of cardiac function. And when we plotted the TAPSE against the running time, it looked like a rather linear correlation. On the gene expression level, the treatment of inhaled iloprost increased expression of IGF and affected PGC1 alpha, a master regulator of mitochondrial function. When we looked at the expression of the prostacyclin receptor protein, we had no effect, and therefore it is still not clear whether that treatment and the changes that I'm documenting here must go through this particular receptor in the myocardium. It may be a different prostacyclin receptor, or it may be a nuclear receptor. It may not be this classical receptor. Connective tissue growth factor expression was somewhat decreased, but not terribly so. And when we looked at a fibrosis model in the dish with myocardiocytes treated with recombinant TGF-beta, we saw expression very quickly within 24 hours of alpha smooth muscle actin, and under the influence of treatment with iloprost in the dish, this was basically prevented. We also used a wound healing assay where you take endothelial cells in culture and you wound them with a needle. Hopefully I'm saying this correctly, that these were, fibroblasts, not endothelial cells, fibroblasts, and then look at the speed of the closure of the wound. It was inhibited quite dramatically under the influence of iloprost. Lastly, when we looked at autophagy signals, we found that the autophagy signals were affected under the influence of treatment with iloprost in the culture situation. So to put this together, we want to believe that the signaling is still going through this receptor or some alternative receptor. We are unsure. But we can say that what happens is a decreased expression in collagen transcription and fibroblast activation, decreased in collagen synthesis, and data not shown to you because I don't have the time, is there's also removal of the fibrotic material under the influence of MMP9 and coupled with an increase in effective autophagy, we think. What about VEGF-B? Well, on the gene expression level, inhaled iloprost had at least a tendency to move the VEGF-B isoform up. So this is my last slide. I want to leave you with a prediction because we are interested in tracking the events when we treat the right ventricle in the setting of pulmonary hypertension. And the prediction is that a drug that improves significantly RV function will make autophagy effective and decrease apoptosis. Second, that there is likely a switch on of an angiogenesis program, and these are the markers that you can use. That there will be accompanying a normalization of the mitochondrial function, and these are markers under there. We think that there will be a normalization of ubiquination and a moving away from proteotoxicity to a normal processing of proteins. We're pretty sure it will affect fibrosis and will decrease inflammation, and these are the markers that one can look for. So, in conclusion, I want to leave the following message with you. Conservation of RV function should be a treatment goal in pulmonary arterial hypertension. Cardiac microvascular endothelial cell function is important and can be a treatment target. And for the start, for what we know right now, at least experimentally, We think that carvedilol, with actions that may or may not be attributable to beta receptor inhibition, and prostacyclin are maintaining RV reserve in pulmonary arterial hypertension, and very likely exercise, physical exercise of the patients may have also a salutary effect. So these are the people that I like to acknowledge. All of them have contributed to the work on the right ventricle. Harm Bogart now in Amsterdam was responsible for the carvedilol experimental work. Jose Gomez did the work on the mitochondria. Jennifer Drake did the work on the microarray. John Bigby, electron microscopy, and Antonio Abate was our very benign, benevolent cardiology friend and consultant. Thank you very much.
Okay, so somebody comes in with bad pulmonary hypertension, double lung transplant. Like a more gradual RV has normalized. Speculate how you paradigm.
Yeah. In this case, you of course reduce the afterload, but my gestalt is that you are reversing the hibernation and the failure program. And the interesting aspect of that is that that can be achieved within a few days. And precisely your argument has been the driving force for the clarion call, do something about the failing right ventricle, because even when it fails, it must not be the final chapter. It can, in principle, be reversed. So I think most people accept that now. The question is to figure out what kind of treatment strategies, short of transplantation, short of thromboendarterectomy, short of atrial septostomy. Those are the three things that we know will rather quickly bring the right ventricle back to life. Short of those interventions, what can we target? And by the way, I will say this tomorrow, we can learn, I believe, a lot from the functional class 1 patients with pulmonary hypertension. And try to figure out what it is that makes those patients not fail, because they don't fail. So yes, I would envision that within a day or two, autophagic flux becomes effective. Autophagy is regulated, and apoptosis will disappear, will decrease. And I would even go so far that factors that suppress the angiogenesis program in the heart are being switched back to normal maintenance of the vasculature and probably towards sprouting of capillaries. But all of that needs to be proven experimentally. I pointed out that there are huge gaps and holes in what I was just telling you. Yes, sir. Well, I'm not an expert in hibernation or what's going on in the left ventricle. The introduction of the concept of hibernation as an end-stage manifestation of right ventricular failure is simply because there is no competing hypothesis at the moment. If anybody has one, I like to know about it. You were talking about treatment with